everyone, I'm Dr. Lahari this side. This is the second part of the salivary gland disorders topic where we're going to discuss about treatment. The learning outcomes of this part of the lecture is to analyze diagnostic workup for a patient with salivary gland diseases, also to explain in detail the management of xerostomia. So, when it comes to the diagnostic workup in a patient with salivary gland diseases, the clinical examination is of utmost importance as the most common presentation seen is dry mouth. So, patients who are having any form of salivary gland disease might first present with the dry mouth. Also, it's important to understand that saliva collection and its analysis, the process of analysis is called as xylochemistry. Salivary gland imaging and salivary gland biopsy are all parts of the diagnostic workup. Let's look at xerostomia. The subjective report of oral dryness is termed as xerostomia. It is a symptom and not a diagnosis or disease. So, that is something very important to remember, that when you are seeing a patient who is having dryness of the oral cavity, the symptom is called as xerostomia and is not essentially a diagnosis. So, the causes of xerostomia could be salivary causes or non salivary causes. The salivary causes could be salivary gland dysfunction caused by drugs which reduce the salivary flow, also called as xerogenic drugs, tumors, or radiotherapy itself. Other examples of xerogenic medication could be antidepressants, anticholinergics, antispasmodics, antihistamines, antihypertensive sedatives, diuretics, bronchodilators, and others like caffeine, alcohol, and cigarette smoking. Non-salivary causes of xerostomia are dehydration, central cognitive alterations, oral sensory disturbances, psychological conditions like depression and anxiety. So it's important to understand here that the salivary causes are more common than the non-salivary causes of xerostomia. So if a patient comes to you reporting with oral dryness, it's important to rule out the salivary causes followed by the non-salivary causes. So clinical features of patient with xerostomia could be candidiasis, fungal overgrowth, generally the erythematous type, because of lack of enzymatic action and the antibacterial antimicrobial activity of the saliva itself. Also, there could be atrophic areas on the tongue, angular cheilitis, which happens due to dryness of the oral cavity, and red areas in the corner of the mouth. Lipstick sign and tongue blade sign, we'll look at these in the pictures that are going to be shown in the next slide. And enlargement of salivary glands, which can be seen by bimanual palpation. What we mean by bimanual palpation is using two fingers or digits, index fingers from two different hands to palpate the salivary gland, both intraorally as well as extraorally at the same time. Upon palpation, it's important to note whether the glands are tender, is the salivary content viscous and scanty, and is the exudate or the saliva that comes off from the duct, is it cloudy, which would indicate bacterial infection. So this is an example of a person with a dry tongue and angular cheilitis, where the tongue appears very dry and erythematous, and the angles of the mouth are appearing raw and eroded, and this is called as angular cheilitis. The other effects of salivary gland or hyposalivation or xerostomia would be high caries index. We are aware that saliva is a very important component in maintaining homeostasis or the balance in the oral cavity. And when there is less saliva, there is increased bacterial count and there is no cleansing action of saliva, which leads to high caries index. Identification of dry mouth can be done by, in case if the patient is wearing lipstick, then you would see that the lipstick sticks to the maxillary anterior teeth, which is a very classical sign of no cleansing action of saliva being present. On the other hand, the tongue blade sign refers to when the mouth mirror gets stuck to the buccal mucosa during examination, and because of lack of saliva, the mouth mirror doesn't slide in the oral cavity. And this sign is called as a tongue blade sign because generally tongue blades or the wooden blade was used for examination of oral cavity. Moving on to saliva collection. Saliva can be collected from major salivary glands, which could be in the form of whole saliva, which is done by draining, suction, spitting, or using absorbent sponges. This whole saliva could be either stimulated or unstimulated. Now, when we talk about stimulated, it means stimulated with the help of an inert substance like paraffin wax. Unstimulated is when you are not um, having excessive flow because of object inside the oral cavity. So various collectors have been designed and used for collecting saliva from the duct of a salivary gland. So in the oral cavity, generally all the saliva that is there is a mixture of the submandibular, sublingual, and parotid glands. So if you were to specifically collect from the parotid itself and analyze the parotid saliva, then there's a special collector called as the Carlson-Crittenden collector, which can be clipped on to the Stenson's duct to collect parotid salivary gland secretions. The similar one used for collecting saliva from submandibular and sublingual glands is called as a segregator. So to identify whether the patient is having hyposalivation, the unstimulated whole salivary flow rate lesser than zero point 0.1 ml per minute or stimulated whole salivary flow rate lesser than zero point 0.7 ml per minute would be considered as hypofunction. So this is how the collection of saliva is done, either by spitting or by the patient passively drooling into a collection tube. And this is the example of how salivary collector, the Carlson-Crittenden selector appears, which actually has a suction cup or a suction ring, which can collect saliva from the Stenson's duct. These are also examples of a modified Carlson-Crittenden device collecting saliva from the parotid, and these are tubes where the saliva can be collected by asking the patient to drool in or just passively by amount of saliva that's produced at its rate, when the patient is unstimulated. So the samples of saliva can be, packaged in sample collectors and sent off to the lab for analysis. Silochemistry is analysis or chemical analysis of the contents of saliva. We must understand that saliva is a complex exocrine secretion containing more than 60 constituents. So saliva these days is used to monitor viral infections, blood alcohol levels, hormone levels, screening for drug abuse, and even screening for cancer and HIV. And in near future, the oral rapid, which is a salivary test, and we are all aware that it has been vastly used for the COVID-19 pandemic as well, where saliva has been used in all RTK samples to um, identify the presence of organisms or viral organisms. So the oral rapid is a salivary kit which helps in identifying both HIV-1 and 2 in the saliva and is supposed to be quite accurate. So this is a example of the first in-home oral HIV test kit, and similar to the test kits that are available for COVID-19 viral infection. Moving on to the salivary gland disorder imaging. Imaging of the salivary glands is primarily done to diagnose and plan management as well as follow up of patients having salivary gland disorders. There are various imaging techniques that have been adopted to visualize the salivary glands, and we will go through each one of these in detail. Let's talk about plain images first. These plain images, I mean plain radiographs. Generally, you use intraoral occlusal views to view of when you are suspecting siloliths in the submandibular duct, or panoramic view when you're expecting siloliths in the parotid and submandibular gland. So mind you, there is a difference in what is written over here. What you're seeing on this image is a cropped panoramic view, is a Staphnase bone cavity. Reason I've mentioned this here is it's not a true cyst. It's a corticated defect in the posterior mandible below the inferior dental canal, and it may contain part of the submandibular gland. A silolith is a common occurrence in the submandibular salivary duct. Uh, we are aware of the reasons why the Wharton's duct is a more common location is because of its tortuous course and location of the duct, and also the components of the saliva that is secreted by the submandibular salivary gland itself. So siloliths can vary in their radio opacification based on the calcification and the density. The X-ray that is shown here is a cross-sectional occlusal view of the mandible, and you can see that there are few radio opacities in the salivary duct, which is the proximal component of the duct, very close to the orifice of the duct. Ultrasonography, high resolution ultrasonography in specific, is a very important method of imaging the salivary glands. Initial assessment of the parotid and submandibular salivary glands can be done with ultrasonography. It is useful for viewing superficial and abnormalities. It is also useful for differentiating cysts from neoplasms and benign from malignant lesions. Ultrasonography is also of use to guide biopsy and advise further imaging choices. The advantages of ultrasonography would be safety because it does not have any radiation involved. Again, the salivary glands are easily accessible, and any calcification within the gland can be noticed, as well as details of the presence of the any anomalies as well as a neoplasm can be noted down. So this is an example of how the parotid looks on ultrasonography, and also color Doppler has been applied, which gives you a clear idea of how the facial artery and its branches appear, and how the submandibular gland appears, as well as how the parotid appears on the ultrasonography. Multi-detector computed tomography is used to display both soft and hard tissue windows to view the salivary glands and surrounding structures. The image viewing after administration of contrast dye gives an hyperdense appearance and is very useful in identifying and diagnosing inflammatory conditions, neoplasia, and lymph node involvement. This is a case where you're seeing a plunging ranula, which is a large space occupying mass seen on the floor of the mouth. It is a well circumscribed cystic lesion predominantly occupying the left submandibular space, causing a mass defect or effect on the submandibular gland. So you can see that the gland has been pushed to one corner, and you can see a large ranula, which is a plunging ranula. CT scan can also be a scout image over which PET scans can be done. This is an example of a squamous cell carcinoma involving the left sublingual space, and an axial contrast enhanced CT image shows homogeneity along with the left sublingual space. And in B, this is an image of PET CT scan. Magnetic resonance imaging of salivary glands would be the image of choice for space occupying lesions such as cysts and neoplasia. The soft tissue contrast is superior, and intravenous gadolinium contrast agents have to be injected into the intravenously so that you can observe perineural and intracranial spread of disease more clearly. This is the normal appearance of a sublingual and submandibular space, and the appearance of the sublingual gland on MRI, as well as the submandibular gland bilaterally on the MRI. And this is just a diagrammatic representation of how the gland would look like on MRI. This is an example of an adenoid cystic carcinoma of the sublingual salivary gland. This is the mass that you're able to see pointed with the white arrow mark. The This image in the sublingual space, it's demonstrating a lobulated mass which is of a high T2 signal and a low T1 signal. It's actually enlarging and distorting the entire left sublingual gland. Also, there is enhancement which is diffuse post contrast. This is an image after the contrast dye has been applied. Xylography is a procedure that was first performed in 1902. It is an imaging technique exclusively used for the parotid and submandibular salivary glands. Xylography involves infusion of the gland ductal system with an iodinated contrast agent, and then imaging the gland with projection imaging, that is plain radiographs, fluoroscopy, CT, or CBCT. Xylography is the only imaging technique that can assess both morphology and function of the glands at the same time, and that's something very important and unique about xylography. The indications for xylography would be chronic inflammatory conditions like obstructions of the ductal system, and contraindications would be acute infections or in cases of immediately anticipated thyroid function test, because the iodine in the contrast agent may interfere with test results. This is how the xylography procedure is performed. For example, locating the Stenson's duct opening and retrograde injection of the dye into the ductal system. So, the example of radiographs taken after the dye is injected. This is how normal salivary, submandibular salivary ductal system would look like, the normal ductal architecture. And this pattern is called as a leafless tree pattern in radiology terminology. If there are strictures in the ductal system, this can lead to the appearance which is called as sausage-like appearance. This happens because the dye hasn't flown consistently throughout the ductal system due to the presence of strictures. A conventional xylogram demonstrates multiple filling defects within the Wharton's duct in this particular image here. This is consistent with the presence of xyloliths, because the xylolith obstructs the duct and the dye cannot completely flow into the gland smoothly. Now, this is another patient where you can see pre and post contrast injection xylogram images, which this is pre contrast injection, this is post contrast injection, and you it easily demonstrate where the obstruction of the duct is happening is because of a large xylolith or a large stone. Xylography in Sjogren syndrome is a very important radiographic feature. Sylectasis leads to branchless fruit-laden tree appearance, also called as a cherry blossom appearance. This happens because after the dye is injected, it is retained in the inflamed salivary acini because of sylectasis, and it is unable to flush out the saliva, and hence the dye remains there, giving the appearance of the cherry blossom or branchless fruit laden tree appearance. Here I have included various images in plain radiograph. This is a crop panoramic image, and this is a lateral skull view. This is images on a CT scan, and this is on the image on a xylography. So post xylography, this is a fluoroscopy image, and CT image and plain images done for after xylography. So like I mentioned to you, after injecting the dye, various methods of imaging can be done to view the effects of the dye in the ductal system. This is the appearance again on a xylogram or after xylography of a normal submandibular salivary gland. You can see the leafless tree appearance, the duct and its entire ductal system and the branches. When there is a foreign body, you will definitely see that there is obstruction. If digital subtraction xylography is performed, this would be the stages of the xylography, and you will be able to see the dye slowly filling out within the ductal system, and it completely fills out here. So this is the injection of the xylography dye. Xyloendoscopy was first used in 1990s. It is slightly different from xylography. In xyloendoscopy, as the name suggests, it is a direct visualization of the parotid and submandibular major ducts. Is minimally invasive. It's a technique which is indicated for diagnosis and management of obstruction, specifically within the ductal system. And Silolith retrieval and stricture dilation tools are available, because of which you can see in the picture here, which can help to retrieve especially an obstruction caused by stones within the ductal system. Again, siloendoscopy is contraindicated in acute inflammations. This is an example of exploration of the Wharton's duct. You can note the diameter of the duct, and it is sufficient for insertion of a surgical endoscope for interventional siloendoscopy. A lacrimal probe has been used in this duct for correct location purpose, and it is important for you to note the location of the endoscope for accurate insertion as well. This is a summary slide of salivary gland imaging, which gives us the imaging modality types and the indications, as well as advantages and disadvantages. So let's begin with plain film radiography. For example, occlusal radiographs, or OPG, or panoramic radiograph, or a PA view. For example, it can be used for visualizing siloliths that are calcified enough. The advantages are that they are readily available, and the disadvantages would be that there could be anatomical overlaps, or sometimes when the stones or siloliths are not calcified enough, they may not be appreciable on plain films. Silography is a procedure that can be used for siloliths and also to visualize abnormalities of the ductal systems. The advantages is an excellent visualization of ductal anatomy and the blockage, whereas disadvantages is that it's an invasive procedure, there is a dye involved, and the procedure needs expertise and could be contraindicated in active infection. Ultrasonography is generally used or indicated in detecting a mass, and can also be indicated in cases of biopsy guidance, especially fine needle aspirations. The advantages would be it is non-invasive and cost-effective. The disadvantages is that ultrasounds cannot be used to detect the function of the salivary gland. Radionuclide imaging, on the other hand, for example, scintigraphy, can be useful for salivary gland function assessment. The advantages are the quantification of function, and they are a method which is non-invasive within the gland itself. Whereas disadvantages are their lengthy procedures, highly cost involved, and radiation exposure as well. CT scan of the salivary gland region are indicated for inflammatory condition, calcified structures, and bony erosion. The advantage would be it gives you excellent visualization of osseous structures and soft tissue, and be easier to differentiate. Disadvantages would be for the salivary gland visualization, a contrast dye would need to be injected, mostly iodine based dyes, and there is a radiation exposure involved. In case of MRIs, they help us visualize neoplastic processes. The advantage would be superior soft tissue resolution and no radiation involved. And MRIs are contraindicated in patients who are having ferromagnetic pacemakers. And also, the procedures can be quite lengthy, and patients who are having claustrophobia may not be comfortable. PET scans are positron emission tomography. It is also indicated for salivary gland function, alterations, and inflammatory processes. The advantages are that they're highly sensitive to metabolic activity. The disadvantages are the lengthy procedures, high cost involved, and radiation exposure. So, when we're talking about management of xerostomia, after having an idea about the imaging processes, it must be divided into preventive therapy, symptomatic therapy, local or topical salivary stimulation. systemic salivary stimulation, and therapy directed at the underlying systemic disease. Preventive therapies involve supplemental fluorides, remineralizing solutions, optimal oral hygiene, and non cardiogenic diet, which all help in preventing the effects of xerostomia, which is primarily seen on the hard tissue structures, that is, the teeth. And preventive therapies prevent in remineralization of the dentine or the enamel, and then prevent caries. Symptomatic treatment, most importantly, is with water. So, after having seen couple of many, in fact, patients who have had xerostomia, they prefer water to any other substitute. So, in fact, to substitute saliva with oral rinses, gels, or mouthwashes, it only can be done to a certain extent, and water seems to be one of the best substitute or the closest to saliva. Saliva, the artificial salivas contain generally lactoperoxidase, glucose oxidase, lysozyme, and lactoferrin, in addition to water itself. They increase the salivary feeling of saliva in the oral cavity and can be used multiple times in a day whenever dryness is experienced. Along with using oral rinses and artificial saliva, increasing humidification and also minimize the caffeine and alcohol intake can help in symptomatic treatment. Topical or local or topical salivary stimulants can be used in cases where there is a residual salivary function left. These help to stimulate salivary flow, and the examples would be sugar free gums and mints, electric stimulation of the salivary gland, and acupuncture of the salivary gland. Systemic stimulation with the help of secretagogues is done in cases where there is uh, remnant salivary function, and this can be done with mucolytic agents like bromhexane, anethyl triethione, which is a mucolytic, pilocarpine, which is a parasympathomimetic drug. It's a muscarinic cholinergic agonist, and this is generally given in cases for head and neck radiotherapy or in Sjogren's syndrome. It comes with adverse effects like sweating, hot flashes, urinary frequency, diarrhea, and blurred vision. So essentially, all the parasympathomimetic parameters are increased, resulting in excessive body fluids. Cevimeline is also a drug that has been used. It is also a parasympathomimetic agonist. So that brings me to a discussion of a case. This is Mrs. Y, who's a 58-year-old female who reported with a slow growing, tender bilateral parotid swellings. She reported that of late she's unable to eat spicy food and had to sip water frequently to chew on dry foods. On examination, there was fissured tongue, and the mouth mirror was found to be sticking to the buccal mucosa. No other lesion was seen, and she also complained of occasional red and itchy eyes. Her medical reports were fasting blood sugar was within normal range, it was just 5.4 millimoles per liter. Blood pressure was 130 over 82 and ESR 36. So, if you were asked for the provisional diagnosis, the most important thing that should come to your mind when you're looking at the infection, at the dryness of the oral cavity, along with components of dry eyes, should be Sjogren's syndrome. Also, two investigations that can help you in diagnosis would again be directed towards Sjogren's. And just as an example, writing a referral letter to the physician for further management of the patient. Another case for discussion, 16-year-old previously well girl presented with fever for 2 to 3 days and with a left-sided facial swelling that had arisen within the previous 24 hours. So it's a very short um, history period for a swelling and fever also. She denied any dental problems. On examination, she had an obvious large tender swelling of the left side of the face, and she was generally unwell. She had received the MMR vaccination at 13 months of age and then at age 6 and had been vaccinated with the MR in the catch up program. What is your diagnosis, management, and differential diagnosis? So, this case is that of an acute parotitis or mumps. Mumps is caused by paramyxovirus and it causes fever, headache, malaise, dry mouth, and difficulty in swallowing. May also cause orchitis in older males and rarely pancreatitis or encephalitis. There is no specific treatment and symptoms resolve simultaneously with analgesics, hydrating with fluids, and mouthwashes. So, when you look at a case like this, the possible differential diagnosis would be cervical lymph node enlargement due to other reasons, dental infection or abscess because it is in the same area, tuberculosis, and possible lymph node because of tuberculosis involvement, which is also can be seen in isolated tuberculosis, secondary tuberculosis without lung involvement, and strictures or calculi in the parotid duct leading to enlargement of the duct and the gland. So, a note on mumps vaccine is the best way to prevent mumps, and this vaccine is included in the combination measles, mumps, and rubella, and the measles, mumps, rubella, and varicella vaccine. Two doses of mumps vaccine are 88% effective on preventing the disease, and one dose 78% effective. Children should receive the first dose at the age of 12 to 15 months, and the second at 4 to 6 years. Adults at higher risk, such as university students, healthcare personnel, international travelers, or where there is a potential mumps breakout, also should get two doses. So that brings me to the end of this chapter. I would like you to go back and read through the textbook for further understanding and better understanding. And please feel free to contact me if you still have any doubts. Thank you.